This case med minute video is going to be on syncope and kind of differential for a fall in an older patient. This is the question we're going to be going over. If you'd like to pause and try it on your own, go for it. Otherwise, we're going to jump in. The first sentence reads, a 78-year-old woman is brought to the emergency department after being found on the floor by her daughter. So, common presentation that you might see in the hospital, and the differential is very, very broad. Of course, could be something like syncope if this patient had loss of consciousness, which is an important question to ask. We think most commonly about vasovagal syncope. So, you're getting your blood drawn, you feel kind of nauseous, lightheaded, you briefly lose consciousness, and then you recover and feel okay. Could be a mechanical fall, especially in an older individual. Maybe she tripped and fell. Could be contributing factors, like maybe she has ataxia for some reason. Maybe she's on some medications that make her more likely to have a fall. Maybe she has some sort of sensory deficit at baseline. Could be something like hypoglycemia. We don't yet know anything about her history, but that could cause a fall. Would present again, kind of feeling not good, and then a fall. Could be something like a seizure. So, seizure often presents with some sort of aura beforehand, and then could have loss of consciousness or not. We often think of kind of the motor type of seizures with rhythmic movements. And then after the seizure, the post-ictal state where the patient is still a little bit out of it. Could be something like a stroke. Stroke, you would see usually some other neurologic deficits. So definitely want a neuro exam on this patient. Could be arrhythmia or ACS, often with kind of cardiac causes. It's very kind of sudden onset without any sort of prodrome. And could be something like orthostatic hypotension, where, when you stand up, your blood pressure should kind of appropriately be maintained when you go from sitting to standing. But if you have a blood pressure drop when you stand, that could lead to a fall. Okay, so the next sentence, she reports feeling dizzy before the fall, but does not recall losing consciousness. So we're already crossing kind of various things off our list. Probably not syncope, given that she didn't lose consciousness, although we can, I would say it's still on the differential. Um, Definitely mechanical fall could be on there, although she said she was feeling dizzy, which makes us think there's something else going on. Um, Probably not something like an arrhythmia ACS, because those often don't have a prodrome, don't have, say, feeling dizziness beforehand, um, and could always be orthostatic hypotension. Her medical history includes hypertension, type 2 diabetes, osteoarthritis, and mild cognitive impairment. So, um, looking at this list, type 2 diabetes definitely jumps out at me. Could she be on some sort of medication that could cause hypoglycemia? Perhaps. Um, Diabetes could also contribute to orthostatic hypotension due to the autonomic neuropathy. Hypertension also, makes me think if she's on medications that might cause hypotension, perhaps if she accidentally took too much for medication or had a medication dose change. And then cognitive impairment certainly doesn't help with this whole picture and makes her more at risk of a fall. So, medication wise, she takes lisinopril, metformin, and was recently prescribed a benzodiazepine for sleep. So, like I was saying, I'm worried about the lisinopril because that could increase her risk of hypotension. Metformin makes me less worried about hypoglycemia, because that is not a medication that causes hypoglycemia. So, I would say that's lower down on my differential. And then the benzodiazepine makes me very worried because this is a sedative medication, definitely has a greatly increased fall risk because she's on this medication. And I would be very hesitant to give something like a benzo to an older patient. So that is definitely like potentially a contributing factor to her fall. On exam, she has mild bruising on her hip, normal heart and lung sounds and no focal neurologic deficits. So great, we got a neuro exam. She doesn't have neurologic deficits, which makes me think that something like a stroke is much more unlikely. And then finally, her blood pressure is 110 over 68 supine and 88 over 54 standing. So she has a drop in blood pressure when she goes from laying to standing. So let's talk a little bit about orthostatic hypotension and whether this would be considered orthostatic hypotension. So you have these receptors that sense your blood pressure. So, in particular, there's one in the aortic arch, transmits via the vagus nerve, cranial nerve 10 to the medulla. There's also one in the carotid sinus, which transmits via the glossopharyngeal nerve, also to the medulla. Both of these respond to changes in blood pressure. And then, how does this work? So, when you have hypotension, low blood pressure, you have decreased stretch of your vessels, and then this decreases this afferent or sensory baroreceptor firing. And then this leads to increased sympathetic firing, decreased parasympathetic firing. And of course, the sympathetic nervous system, that fight or flight system, causes vasoconstriction, increased heart rate, increased contractility of the heart, which all in all leads to elevated blood pressure. And so normally when you are laying down and then you go to stand, the blood will kind of be pulled down by gravity into your legs, causing this transient decrease in blood pressure. But your receptors should sense that and kind of make these changes to put your blood pressure back up to normal range. If you have some sort of problem, like I was saying, maybe autonomic neuropathy from diabetes, for example, that causes this system to not work quite as well, then you may not have that appropriate increase in blood pressure. And then your blood pressure would drop when you go from sitting or laying down to standing. So that's what's happening in this patient. And orthostatic hypotension in particular is defined by systolic blood pressure decrease by at least 20 millimeters of mercury or a diastolic pressure by at least 10 millimeters of mercury within 3 minutes of standing. And in this patient, we go from 110 to 88, which is a difference of 22. That's greater than 20. And then 68 to 54, that's greater than 10. So we fit both these criteria. We only needed one, but we fit both. So this patient has orthostatic hypotension. And how does this contribute to a fall? Well, if your blood pressure drops, you can imagine you have kind of less blood going to your brain. And this can lead to kind of instability and likelihood of a fall. So, which is the most likely contributor to her fall? Well, we've already said we think orthostatic hypotension. And as far as causes of orthostatic hypotension, I just put some of them on the screen. This is from SAPRLS. Could be neurogenic, so things like neurodegenerative diseases, could be caused by peripheral neuropathy, like I brought up diabetes for this patient, but could be other things like, for example, vitamin B12 deficiency. Could also be non-neurogenic, so something like volume depletion. We don't know much about this patient. Is she dehydrated? Is she anemic? Could be related to cardiovascular disease. This patient does have hypertension. And also could be other causes like adrenal insufficiency is one that often gets tested for, or physical deconditioning and aging, which is probably part of this patient's picture as well. Let's go through the other answer choices. So vasovagal syncope, probably not likely or not as likely because this patient doesn't recall losing consciousness. She does have this dizziness, which could be part of a prodrome for someone like syncope, but she didn't lose consciousness, so I would say less likely. As far as an arrhythmia, this often happens suddenly without a prodrome. This patient was feeling dizzy. She also didn't lose consciousness. So I think that's probably less likely, but I definitely would want to see an EKG on this patient. Environmental hazards, maybe, but she's not telling us that she like tripped on something. But it definitely would be a good idea to, have someone visit this patient's home, check for things like slippery rugs or slippery tiles in the bathroom, make sure there's handholds as needed to kind of help prevent a future fall. And then hypoglycemia, again, she was feeling dizzy, but she doesn't have any other symptoms of hypoglycemia. And she doesn't have any, medications or kind of any reason for us to believe that she has hypoglycemia. So orthostatic hypotension definitely seems like the most likely choice here. And in fact, that is the answer. They didn't bring up benzos in the answer, but I think that is also definitely a strong contributing factor. And I'd say it's probably those two things that contributed to the fall in this patient.